welcome all of you on behalf of the One Lamb Initiative for being here today and coming to hear these two wonderful ladies. This is Beth Casey and Jessica Alfred. And Beth is the CEO and founder of Caravita Home Care and care there.
Senior care.
Senior care. And she has been in this business for over 46 years. So she has a lot that she can share with us. And another interesting thing that I learned in talking with them is that she started in Kenya a program to help. They didn't have enough money over there, and she went over there and started ministries in Kenya. And now they're over 150.
There are 150 pastors present in ministry.
In helping people with dementia and senior care. This is Jessica, who has been, who is the director of dementia care at Caravita, and she has been in numerous states teaching before she came to Caravita and therapeutic help for people with dementia and Alzheimer's in a number of states before she came and settled and found that this was her thing that she liked to do to be able to help other people. Before they begin, I would like for you all to know, if you see on your sheet, and those on the back row, there may not be one. Oh, you did have it. Okay, well, just grab one from up. On there, I have a BDT tour, and what that is, it's a virtual dementia tour. And on that tour, you are put in the shoes of a person that has dementia. So I have done this and it helped me so much with my husband who has frontal lobe dementia. And I will tell you, it gives you a good perspective of things that they have difficulty with. That's going to be on this Wednesday from 12 to 2. And as you leave, if you will hand those to the people that I'll have at the doors, with Lauren and Martha and myself, then you can, I will call you tonight and let you know what time that you will be coming. We've already had people sign up for that, so if you're interested, please do. And there's a slide on there that says if you can't do it on Wednesday, just say you're interested and I'll get back with you at another time. But I won't be calling you tonight if you're going to do it at a later time because I'll have to get it set up. So welcome everybody, and with that, I'm going to turn it over to these two ladies.
Okay, what we want to do, and we know we just have a brief amount of time with you, is really talk a little bit about dementia, but primarily about the behavioral expressions that someone has with dementia and maybe why they have it, and then try to talk with you about how you can understand those behavioral expressions and then to create a fuller life for your loved one who's journeying through dementia. So that's really going to be the focus of what we're talking about. I'm so excited to hear that y'all are going to do the virtual dementia tour, because a lot of what I talk about today, when you take that tour, you're going to understand what this means. And I always tell people, I can tell you verbally all of this, but when you feel it yourselves, changes your total perception. So if you can do that, I highly recommend it. I'm going to go ahead and let Jessica begin, and we're just going to have a conversation. We are going to leave time at the end for questions.
So as Beth said, we're going to spend a little bit of time in this first section talking about behavior. I'm sorry?
Maybe just get a little closer to the mic.
Okay, I'm sorry. Is this better? Yeah. Okay. We're going to spend some time in this first section talking about behaviors and some more appropriate common responses.
This is a model that was developed by Cohen and Mansfield, but I actually think it's a really good diagram to explain behavior when someone is having behavioral expressions with dementia. Realize there's multiple types of dementia, but pretty much all of them fall into the range of how behaviors get categorized. So you're going to have a person who's got their own habits and personality. That means I might want to be an in-charge person. And if I am, that's going to continue whether I have dementia or not. I may have some type of physical condition or I'm more anxious, or I may have a physical need, or I may be overly stimulated by the environment. One of the things people will tell you when they have dementia is they're unable to filter sounds. Okay, all the noise comes in at the same time. And so while you and I may filter out an air conditioner or the buzz of the lights, or even me with the microphone here buzzing, they're not able. All of those sounds will come in at the same time, and it makes it very, very difficult to focus. So when we look at people's habits, and we look at their current physical condition, and we look at the environment. So let's say someone has a behavioral expression, and let's use the example of not wanting to bathe, just being highly resistant to wanting to take a bath. So what we have to look at is we have to determine to manage that behavioral expression, because I don't like to label it as behavior. I don't like to label it as you're aggressive, you're agitated, because there's a reason behind the behavior. It's not that they're agitated, it's that you're seeing that as an expression of a need. So we look at what is the unsatisfied need. So the first thing we want to do when we start examining that is, what would satisfy that need? Can I figure that out, and could I do that? Or are they communicating a need that I need to satisfy or try to fix a condition for them? Or lastly, do I need to eliminate some type of condition? This model will work for all behaviors for you to help analyze them. So let's use a simple example like I began with. My mother doesn't want to take a bath. Highly resistant, having a behavioral expression, getting more and more resistant, pushing me away, beginning to tell me, I don't want to do this, I don't want to do this. What we can look at is what we call the antecedent behavior that comes before that. I went in there and I knew that she needed a bath, so I was going to just say, Mom, we're taking a bath. I didn't give her a choice. I didn't ask her if she wanted a bath. Of course, you're probably not going to ask that, because you're probably going to get no. But I was taking my personality and like, we're going to make this happen. Not realizing that my mother has a personality that she needs to be in charge. And she needs to be in charge, and she needs to be comfortable with a situation that is not comfortable to her. And a lot of times what we see is, we as caregivers, and I can tell you this myself, I've had 2 of my own family members that I've journeyed through with dementia, and I wasn't doing things exactly right, and I got a lot of these behavioral expressions because I was very task-oriented. We got to get a bath, we got to take medicine, we got to get to the doctor, we got to do all these things. So I, as the child, was like, we got to have this, just like the spouse. And our whole life becomes task-driven, not people-driven. Simply changing the approach. You can simply work with maybe making the bathroom nice and steamy, putting the towels in the dryer, making them nice and warm, having a cup of coffee. Don't talk about the bath, just kind of go into the bathroom casually, and all of this is in motion. Have a cup of coffee, get up slow, talk about how good that tastes, talk about someone's coming over, you walk into the bathroom, it's nice and steamy, and you just begin very gently. It's not a push to get a bath, you're just gently, Mom, I'm gonna help you, okay? Totally changes up. And you can get referrals, so there's occupational therapy, Jessica and I are both therapists. You can get therapy referrals that will help you with this. But I often find, if you're really good at knowing what motivates someone, I tell people, when you're trying to get a best friend, or you were previously trying to get your husband and wife to do something, you know a little bit about motivation. You know how to set up a situation so it's more pleasant than unpleasant. And so this is what we do with bathing. And sometimes it might be just simply, we're going to go with a sponge bath. But that still means I make the whole atmosphere pleasing and relaxing, and I just move into it. I don't just say, we're taking a bath now, you're on a schedule. Because a person who's in charge doesn't want to hear that. I had a 92-year-old gentleman, and he was highly resistant to taking the bath. And his daughter was just like, oh my gosh, I can't believe my dad, he was always so well dressed, what can you do? And I just started asking her, tell me a little bit about him. She said, well, he loves to get up in the morning and have his coffee. And he loves to read the news, and he can still read the paper. I said, well, why don't you do that with him a while, and why don't y'all just really have a good time doing that? So she did, and I said, well, then the next thing, make sure that the bathroom's all warmed up, and the towels are nice and warm, and just say, Joe, let's walk in here. And you just go in there and say, oh, this is nice and steamy. Can I just help you freshen? And just make it a nice experience. And the next thing I know, she's saying, well, you know, that's kind of working. And I said, well, that's because you didn't go in there and tell them it's time to get up. You're going to get up, you're going to take a shower. You know, you weren't on the task, you were on a relationship. And that's what we talk about, learning to satisfy need. And it'll work for a wide range of needs that people have.
So when Beth and I talk about the stagings of dementia, and anytime we do education and training, we will label these in 5 different levels. Level 1 being the very early stages, and level 5 being towards the end stages. So with level 1, some common behaviors that we see, inflexibility. This person is going to be very set in their schedule. This is the person that gets up at 8 a.m., has their coffee, their newspaper at 8 a.m. And if it comes in at 8:05, it is late, and it is going to set off the entire morning, sometimes the entire day. So what we can do with this is we can set up reminders to cue and guide this person. We learn their routine and we respect it. Because I'm sure at least a couple people in this room, right? We try and go in and say it's time to get a shower, here's your coffee. I know it's 7:30, but I have the coffee ready, thought you might like to have it now with your newspaper. Sometimes that starts a whole fight. No, I don't want my newspaper and coffee right now. I get it at 8 o'clock. And I use this example because I had a gentleman I worked with who was like this. He got his coffee and newspaper at 8 a.m. If I showed up late with it, it ruined the whole morning. But I did have one of the first experiences with him. I came in 7:30. He said, you know, I thought that we'd go ahead and get our coffee early. We can sit and talk about the newspaper. He said, that's very nice, sweetheart, but I'm not drinking this coffee, and at 8 a.m. you're going to need to bring me a fresh cup of coffee. I said, okay. We'll see them start to repeat stories and questions, but it's not going to be back to back. As we get towards the middle stage, more towards the middle stages of dementia, we'll see people repeat questions and tell stories, within a couple of seconds or minutes of each other. I know that we've worked with many, many people, and some of you may have experienced this yourself, where you have someone that says, what time is it? I need to leave at 2 o'clock because I have to go pick up my child from school. And you say, oh, well, it's only 10:14, so you've got some time. Okay. And then they come back 30 seconds later. What time is it? I need to go and leave at 2 o'clock to pick up my child from school. Well, now it's 10:15. You still got some time. We never want to say, don't you remember? When we've got people asking questions or repeating stories, we never want to say, don't you remember you told me this already? Or, yeah, I know, Dad, you told me this story already this morning. I know that Cousin Jimmy came to visit, and I know what you guys did, and I know what you guys said. Because this is just going to turn into one of 2 results. People either become very agitated and say, I didn't tell you that. I would have remembered if I told you that already. Or they're going to become frightened. Especially people that are aware of their diagnosis and aware of what to expect. They will suddenly say, oh my gosh, I don't remember telling you that. And I trust you and I love you. So I know you're not lying to me. Does this mean that it's getting worse? Does this mean that I'm progressing now? We can also see paranoia and suspicion happen at this stage. They'll blame people for taking things. They'll blame people for losing things. The big thing we can do here is to be empathetic and help them, right? Oh, I can't find my lipstick. I know you took my lipstick. You stole my lipstick. And I use this because this happened to me once before. I had a lady I worked with who accused me of taking her lipstick. Now, oftentimes what we see is people will say, I didn't take your lipstick. I don't even wear lipstick. What do I want to share your lipstick with you for? If I want lipstick, I'll buy my own lipstick. What we should do instead is say, oh, I'm so sorry we can't find the lipstick. It's such a pretty color on you. Let me help you find it. What brand is it again? Does it have like a fun or a special name? Because some of these lipsticks have fun and special names. Have you always worn that color lipstick? And this is what I did with this woman that I used as an example. Have you always worn that color? Oh yeah, always worn bright red. It's always been Revlon red. So we want to try and help them look rather than say, I didn't take this from you. So when we progress to level 2, this is more of our mild moderate stage. So what we're going to start seeing happen here is what we call time traveling. So this is the person that will get up in the morning and generally know that they're older, they've got kids, grandchildren, sometimes great-grandchildren, but then a little bit later in the day, they will think that they are 30 years old and need to go get their children from school. Or sometimes we find they revert back to childhood and think they're 10 and they're excited because daddy's going to be home from work in a little while and they're going to get to play together. The best thing we can do when we are presented with this type of behavior is to meet them where they're at. We don't want to try to bring somebody back to the reality because this is not their reality. Their reality is that they are 10, daddy's coming home from work soon, and they're going to get to play outside. So we ask questions. What time does he get off work? Where does he work? What are you guys going to do today? What do you usually do today? You can introduce the weather. It's really nice out. Are you guys going to go outside? Are you going to ride bikes? What are you going to do? This person we also call our purpose person. This person is constantly looking for things to do. This person is in all the closets, in all the drawers, wandering around, trying to go outside, trying to leave, getting into everything. This person is also one that might come up to you and just kind of stand there and look at you and then say, what do I do now? What are we going to do next? Where do I go? Because they have this part in their brain that we refer to as the starter button, this piece in their brain that's telling them there's something I'm supposed to do, I'm just not sure what it is. And if I rummage around enough and I go into enough rooms and I ask enough people, something or someone is going to tell me what I'm supposed to do next. This is why we start to see hoarding behaviors as well. So people that are like the hunter-gatherers, right? They walk around and they collect a bunch of things and just keep them with them because they see something and they'll say, oh, this looks pretty good. I might need this later. Oh, I might need this thing later too. So that's why we see that behavior happening. The best thing we can do here is provide them with that purpose. Establish a functional schedule, keep them to that schedule, and give them activities that bring them joy and purpose. Sometimes it's something as simple as folding socks, wiping down counters. I love people at this stage, women at this stage that are homemakers because they love to fold socks, they love to dust, they love to do very simple activities that don't require a lot of setup or breakdown. And they thoroughly enjoy it. It gives them a sense of purpose. I mentioned wandering a little bit already. This is the person, like I said, that's kind of wandering around, getting into everything. Excuse me. Again, this person is looking for something to do. So the best thing we can do here, is walk with this person and cue and guide them. A lot of times we find that people are wandering because they're looking for the bathroom. Whether they've moved into a new community, we also find that when children move their parents in to live with them and the parent is not used to that house or familiar with that house, they're having difficulty locating the bathroom. So you just start walking with that person. Hey, what are you up to? How you doing? Just chat and you can find out what it is they may be looking for, what it is they may need to do. The bathroom is like showering is one of those that if we ask, do you need to go to the bathroom? 99% of the time, you're gonna get a no. I don't need to go to the bathroom. So what we tend to do here is we will guide that person towards the bathroom, and a lot of times that visual cue of the toilet or the bathroom gives them the opportunity to make that decision on their own. Oh, actually, you know what? My bladder does feel full. Or I've had my grandmother, we used to do this for her, guide her towards the bathroom, and she'd say, well, I'm already here, so I might as well just go ahead and try it.
So as Jessica said, there's a lot of things that are going on with someone trying to figure out what to do. And a coping mechanism sometimes that we see is what's called shadowing. That's where someone will constantly follow you about what you're doing. Now this can be helpful if you're trying to establish a routine, because if you start getting a routine, not where you're pushing, we gotta do this, but you just start to do it, and then they join in with you, that's a way of them getting a cue for what they need to do next. So it allows them to get chores done. So as we'll talk a lot about, we have a handout we can give you where you can start thinking about someone's life story and maybe perhaps how they lived, maybe not the last 10 years, but back in their life, what a routine might look like and how it might just follow you through that day rather than it being a routine of tasks. The other thing that we really want to caution you about, and I'm all about taking care of ourselves as caregivers, because when we're burnt out, we don't have anything else to give. I know this happened to my mom and I taking care of my grandparents, and we didn't have a lot of resources back then, which is why I'm very committed to this, to help people understand that you do have resources. If someone starts to get latched, that means that they really are codependent on you. They absolutely get incredibly anxious if you're going to leave them, if you're not going to be around. You are their sole way of navigating the world. And the problem is, we all believe as spouses, or as loved ones, we should always be there for our parents and for our spouse. But the problem is, we've got to think about how being there is. If being there is being burnt out and not being emotionally available to employ some of these strategies because you're on your last nerve, then we're not really being there. We're physical, but we're not really being there. So what I talk to people about latching is you need to give yourself some space. And at the end of this talk, I'll talk about if you bring in someone else or introduce someone else to help you in managing, a day or giving yourself a break, why that's important, because you need to introduce other people so you don't have this incredible anxiety when you're not there. Because that's not good for the person or for yourself.
So now we'll talk about our level 3. This is more our moderate stage. We're going to see a lot more rummaging here. People, again, looking for something to do. We'll see some restlessness happen as well. Most of the time towards the end of the day, this is when people would start to say, oh, this person is sundowning. This is something that just kind of happens. What we find is that, and Beth will talk a little bit about lighting later on, but what we find is that as the sun is shifting towards the end of the day, there's some confusion about what time of day it may be. They don't know if it's early morning, they don't know if it's at evening. We see as well, especially in communities that we visit, and then even with the private caregivers that we have, they'll see people leaving, wondering, well, they're leaving and where am I supposed to go? Or going back to this kind of latching, if they see you going, what am I going to do? Who's going to take care of me? What's going to happen to me? So we try and engage them with some physical activities. We like to use music, have them dance, give them something really to focus their attention on. This is also when we will see inappropriate touching happen. Sometimes this can be highly inappropriate, right? Genitals, feces. Feces is something that we see very commonly, but this person is simply sensory seeking. We talk a little bit, I think later on, about how their world shrinks. And so their world gets to a point where it's so small that if they don't have anyone or anything directly engaging with them, they're going to seek sensory input somewhere. And they're going to seek out something that is pleasant sensory input. So what we can do is try and find something to redirect them, engage with them, and try and find something that's going to provide that positive sensory input. One thing that I've found very successful with those that are rubbing the feces is, because we find that to be a very, very common behavior when we get toward these middle and end stages. You all know about they're like the heating pads you can heat in the microwave. They've got the rice or they've got little beads in them. Sometimes they smell like lavender. That is a wonderful intervention that I have found works for inappropriate touching, no matter what it is. You heat it up in the microwave, it gets nice and warm, they can manipulate that with their hands, they can smell it, so they're getting a lot of different senses activated just with this one simple thing.
So one of the things you want to think about when someone is showing behavioral expressions of being more agitated or a little bit more aggressive is you want to do what I told you earlier. You want to figure out what is that need they're trying to express. Are they cold? Are they tired? Are they hungry? Are they hurting? Sometimes we can do this with questions, but sometimes we have to be a detective and begin to figure it out. If someone is just not acting their normal self, there's some common things we start to think about, and they're on the medical side. Maybe they have a UTI because they don't manage their bladder like we do, okay? And maybe that's the situation and you need to check that out. That's pretty common. It could be they could be constipated, and we're not watching when they go to the bathroom all the time to know if that's the situation. So that's another thing that we look at. But they also maybe simply, I had one lady at the end of the day where she would just stay up and she kept doing this. And finally I realized we put all of her beautiful comforters away because we didn't want anything to happen to them. And all she was looking for was when she used to get ready for bed at night, she would put the comforter over and sit in a chair. And that's really what she was showing me with her need. So it's amazing some of the needs that you'll have. I'm going to tell you one really bizarre story. We had a woman who got incredibly agitated at lunchtime. Very, very agitated. We had no idea. We asked her daughter, she didn't know what was going on. So I said, well, we just got to probe and go back further in her life. So I said, when your mom and dad were first married, was there anything particular around noontime? Because you told me your dad worked in a factory. She said, yeah, he came home every day when they blew the whistle, and she had to have that lunch on the table. He was pretty much a taskmaster. If it wasn't there, he couldn't eat that lunch right then. He would get unwound with her, and he wasn't very kind. And I'm like, oh, okay. So something was triggering with lunch, and she was supposed to be doing something for lunch, and this was an old memory for her. So what we decided, she was living in a community, is we'd start letting her help us with lunch, setting up the table, being involved, complimenting her, telling how wonderful she'd gotten it on time, all the things that she needed to hear from her past life for that level of fulfillment and purpose. And lo and behold, within a couple of weeks, the behavior went away. So you just never know when you start to dig in what you're dealing with. People are working through, all of us, all older adults are working through our lives. As we get older, we tell our children stories, maybe not as much as someone journeying with dementia, but we tell them things that are important to us over and over and over. That's leaving your legacy. Well, the person with dementia is similar. They're working out things as well, even though their brain is not connecting. And once you satisfy that and they're comfortable, they also can begin to move on. So just something to start thinking about when you start to see kind of strange behaviors.
So as I said earlier, when we talk about the different stages that we see, we go through levels 1 through 5. The last one we talk about today is going to be level 4, just because level 5 is more of the end stage, and that level is mostly just about making sure that someone is comfortable and content. So level 4, this is our more severe stage. Very commonly what we see is crying. This is usually a sign of loneliness or distress. By this stage, most people have lost their ability to verbally communicate. And so again, if they have no one engaging with them, no one trying to either talk to them or just be in a space with them, they will have this sense of loneliness. So that distress comes out a lot of times in crying. The best thing we can do here is comfort that person. And this goes back to what Beth was talking about, the life story, and knowing the things that a person might like, their interests, their hobbies, because people can still participate in their interests and hobbies well towards the end stage. I had a lady that I worked with who was an avid reader. She loved to read. And she got to obviously where she couldn't read anymore. But the one thing we found that would calm her when she was having these moments of distress is we would read to her. We tried audiobooks, that didn't work. She physically wanted someone there close to her to know that we could reach out and touch her occasionally and just read to her. Patting and tapping is something we see very commonly as well. So this is the person who might be sitting and just kind of tapping the table or the chair, or they might tap their hands. This person, again, is sensory seeking, so we want to find something to occupy their hands. So now we're going to talk about dementia and vision. Stereotypically, when we think about dementia, we think about memory loss. And I think that most people don't realize how significantly vision is affected by dementia. So I'm going to invite you all to do a little bit of an exercise with me here. In the early stages, we find that people lose their peripheral vision. So everybody put your hands up for me like this. So in the very early stages, this is what they see. Now, very, very early, people have the cognitive awareness like us to where we can say, oh, let me look to the right, let me look to the left. But eventually they get to where they don't think to look to the right or the left. Next, they move into this binocular vision. Do your hands like this. So now you should really only be able to see what's in front of you, right? You can't really see what's below or above. And by this stage, they've lost the cognitive ability to say, oh, let me look up and down and left and right. The later stages we move to, they move into this kind of monocular vision. Meanwhile, that distance is closing in, to where when they get towards the end stage, they get to a point where the world they exist in is about this big. So again, when we're talking about these different stages and the importance of engaging with folks, it's very, very important that we keep in mind how vision is affected here. Because if we're sitting, if Beth is sitting over here by me and she's talking to me, but my world exists right here, I have no idea that she's here. She may be reading me a book if I'm that lady that likes to read. She may be singing to me, but I have no idea that that's happening. So as the disease progresses, while sometimes, we may think of it as a little invasive, it's important that we are close to that person in their space so we know that we have their attention when we're trying to engage with them. So this next picture, I think, is very powerful because this is something that they would see. This is how this person would view the world. So you and I can look at this picture. You can kind of see outside the ring where the buildings and things are, but this is what they see. And imagine, I like to think when I do this picture, imagine a hallway in a home or in a retirement or senior living community. A hallway that just seems to stretch on and on and on. They don't know that the rooms are to the side. They don't know that there are staff members walking by. And then when people do walk by and just seem to come out of kind of nowhere, it's no wonder that people are startled and become agitated because they're startled. They had no idea that you were there, and you just come up behind them and you say, "Hey, good morning, Miss Jessie, how are you doing?" That would give me a heart attack. So as I said, this kind of just reinforces what I've been saying, right? Their visual field shrinks significantly. We see them move through the visual field loss stages, peripheral, binocular, monocular. So again, it's just important that we keep this in mind when we're trying to engage with people that are journeying through dementia.
The next one I want to talk about is probably the most frequent place that we see accidents occur with someone with dementia is in the bathroom. And these usually result in falls. A lot of people say, well, they just fall and they just fall. Well, 25% of the people that are going to fall and break their hip are not going to live more than a year. People do not realize that falls have high mortality. And the people with journeying with dementia, it's even higher. It could be as high as 40%. So it is something that we really want to take a lot of consideration for. So these are just some simple things you can even do in your home or they can do in the community where they live. If we have a night light that can be motion censored, you can just stick it up underneath the bed so when their feet go down, the light comes on. Or you can have a simple, very low light, yellow colored, not white, not blue, but yellow colored in the room that kind of illuminates. The next thing we want to do is we want to light the path. And you, for $25 to $40, can get those strips that are motion censored, and it will light the path to the bathroom, and likewise the door, or maybe having the door open. Well, why is that important? Well, it's important because you and I know that when we wake up in the night, we kind of scan like our thought about what the room is. The person with dementia can't do that scan anymore like you and I can. But they can get the clues that we give them. So what we're doing by giving them these light cues and having that low light on is, it's helping them put their body in space because they don't know where their body in space is because it's all dark. But this allows them to have that whole horizontal, vertical view, where am I going? And what they found for research is it decreases falls because they don't sway as much and because they don't stumble with their step, trying to figure out where their step needs to go. So these are very, very simple solutions that can really help in the home and in a community for someone who's trying to get up and go to the bathroom. And the reality is they're not always going to call for you because they're impulsive. They don't remember they need to call for help, so they're just going to get up and go to the bathroom. So we want to do some things that are preventative. Oh, this one's me too?
Oh, no, maybe this one.
Okay.
So we've already mentioned a couple different times, right? Behaviors are simply an expression of an unsatisfied need. Now, 50% of the time, even though we might not realize it, the behavior that we see is because of how we interacted with that person. I love to use an example here of my friend George. I a big chunk of my career has been spent in skilled nursing facilities, primarily doing long-term care and memory care, dementia care. And this particular facility I worked in had a long-term care patient who we'll call George. He was always on and off therapy, but anytime he was on therapy, I was the therapist that worked with him. We had a great relationship. He couldn't remember my name usually, but he knew me from somewhere and knew that he liked to spend time with me. So I go in to see him one day, and I just go kind of prancing into the room. I said, "Good morning, George, how you doing?" And the reaction I get is, "Get out of here, nurse. I said, "George, is everything okay? It's Jessie from therapy. I'm here to come and see you." "Get out, I'm calling the police if you don't leave." "Nurse." I said, "Okay, I'll go. Do you want me to come back later?" "Don't you dare come back." I said, "Okay." So I left, and he was fine, right? You make sure that he's safe. I leave, come back about 10 minutes later, and changed how I came into the room. Didn't prance into the room this time. Knocked on the door. "Good morning, George. How are you doing?" "Good morning, how you doing?" "May I come in?" "Sure, come on in." So I'm talking to him for a second. I said, "Can I sit with you for a minute?" "Sure, sit down. So I sit, and we're talking for like 2-3 minutes, not really long. And I said, "You know, George, why don't we get out of here? Why don't we just kind of go around the building, see what's going on?" Because he liked to stroll around and talk trash about everybody. So we're going around. I said, "Let's get around, see what's going on. We'll go up to the gym. We'll see what's going on up there. And if you feel like it, maybe we'll do a little exercise." He said, "That sounds good." So I go to unlock his wheelchair, and I go to wheel him out, and he stops and he goes, "You know, I'm so glad you're here. That little girl they sent in earlier was awful." And I said, "Make sure we don't send her back." But the important thing here, and when we have some lengthier talks that we give about validation and communication. And what I did in this moment was, whether it was how I came in the room, whether it was something that happened before I got there, George was having some feelings, right? He was in a certain kind of space, and I was not helping his situation. So I validated that he was having those feelings, that he is a person, and whatever was going on, I respected that, and I left. A lot of times what we see, unfortunately, is, "Oh, George, don't worry about it. I see you every day. Come on, we're gonna go do this. You're gonna be fine. You're gonna have a great time." At no point would I have been validating who he was and what he was experiencing in that moment. And we see that very often because, again, going back to what some of the verbiage Beth used, we become task-oriented, right? We have in our mind, these are the things we need to do right now because we have these 10 other things we have to do later.
So what Jessie did was something that we recommend to you is, person with dementia is processing slower than we are. So we want to give them lots of cues about what's going on. So when she came into that room, she gave a nice visual. She gave George hi. She let him process, "I'm saying hi to you," okay? Then she gave him a verbal, okay? So that gave him another sensory cue. And lastly, she went over and reached her hand out to touch. We call this the positive physical approach, where we give multiple cues to someone in a slow method that allows them. And people say, "Oh, that's kind of hokey." Well, it is difficult to learn, but it absolutely will work. I have found in my practice of 45 years that literally, when I don't do it, I get the response Jessie does. When I do it, I get at least a 90 to 95% that I'm going to get the person engaged. So it's a visual, space a minute, give a verbal, and then some type of gesture, whether it's a handshake or a touch or whatever. That's giving them time to catch up with you because they're not processing as fast as you're processing. Their visual field is narrowed and you're coming into it. So they've got to see you in that field, then they've got to feel that you're giving them warm fuzzy, and then maybe even additional through touch. And that really, really works, especially like if you're trying to wake somebody up in the morning. It's very, very helpful.
Yeah.
Oh, you did it? Okay, so if we're going to try to get someone to do something, people say, "Well, I can't get mom to do X, Y, Z." Part of what you need to understand with also those cues that I've talked to you about is that someone with dementia could take anywhere from 90 seconds up to 5 to 7 minutes to process, depending on the stage they're in of what you're saying. Another thing is we're talking. We go and we see a friend and we say, hi, how you doing? You know, what's been happening? You know, I did so-and-so. We're at least a 3 or 4 sentences. That's just how people talk. What you need to know is that when someone has dementia, in the very early stages, they can process maybe 3 sentences, but once they start moving and they go to the moderate to middle stage, they may only process 1 sentence. And by the time they're at the mid stage, they may only process phrases. Now that you might get them from a phrase up to a sentence after 5 to 7 minutes, but they're not processing all those words you're saying. Even though you're saying them and it feels good to you, they're not getting all those words. So we have to start thinking about, when we talk with people, figuring out how many words we think they understand, and can we fill it in with gestures, okay, in terms of what we want to do. For instance, a choice. Do you want to wear this today or this? Very simple. We don't need to make it difficult. Okay, you want to use motivators when you talk. And you don't have to say, well, I know you really like coffee, so I brought some in here. Would you like it? You lost them after the first sentence. You know, just bring the coffee in and say, smells good. You know, hold it over there and let them experience that. You don't need a ton of words. And in fact, if you get too many words, it actually makes them feel more agitated. Okay? The next thing you want to do is, what's going on in their brain is the very beginnings of dementia, and at least the Alzheimer's particular, not so much the frontal temple, is they start losing that ability to do steps. You know, like one step after the next, after the next. So what you want to do is break it down and start to help with a step, let them get going, help with another step. Sometimes I see this when I'm helping someone eat. I may simply cut the meat up, and they're looking at the utensil because they don't know what to do with it. They don't know how to manipulate it anymore, because you lose that ability for your, what we call stereognosis, to understand what it is that you have in your hand. So I may simply put my hand underneath theirs and guide them and get them started. Once they're started, that's an old memory. They're going to do hand to mouth. And they'll do that until their attention wanders, and then I'll give them another cue. Likewise with dressing, I might give them a cue by just simply talking to them and getting real relaxed, showing the shirt, and then just kind of point where their arm goes in, and then they'll just pull it around. You know, one of the saddest things I see is when people are dressing an older gentleman. I'm like, you don't need to dress an older gentleman even in mid-stage. If you set him on the edge of the bed and you put the pants in front visually and you tap that leg and say, put it in, he's going to put it in. It's an old memory. People with dementia have old routine memories. We need to use those. So those are the ways that we work with getting someone to do something. Okay. Remember I talked to you about dementia and how you have to take care of yourself. This is a family disease. And the reason it's a family disease is we're all held together by what? Memories. Memories of things we did in the past, memories that we're looking to create. It's a stream of consciousness that we have as a family. So when one person is journeying through dementia, we're all journeying, and we all deal with it in different ways. Next slide. So what I tell people is, you're going to go in and out of different stages just like you do with grief. You're going to have that whole situation at the beginning. Well, I thought maybe she had dementia, but oh my gosh, you know, she's still talking to me on the phone. Or you may have one family member that they're doing fine with on the phone, but they're not doing fine all day at home or at night. That's the denial. You can be really angry. And this is where the caregiving gets difficult, because you're saying, don't you remember, or I'm doing all this for you, and I can't believe you don't want to do it. And I see this, and it's hurtful. And I say to them, they're just angry. You're going to have to learn to work with your loved one in a different way. And I'm going to talk in a minute about recasting that relationship. The next one is bargaining. And bargaining has to do with, well, if only I did this, this wouldn't be so bad. If only I was there, you wouldn't have fallen. Or if only you'd done this at the community, this wouldn't have happened. Because we really believe in bargaining, that if something happened, it wouldn't have happened. That's not necessarily true. It's just part of what we're dealing with and how we're processing this. Then you get to the, oh my goodness, this is how it is. And people go in and out of these states as they're journeying with somebody with dementia. But the best part we hope to get people with the different types of training that we provide is to that level of acceptance. My mom or dad has dementia. It's a horrible brain disease. but they are still a wonderful person, and I'm going to let them live a meaningful, person-centered life. And I'm going to learn how to do that with them and journey. I'll tell you a beautiful story. There was a woman whose husband got dementia. They'd been married for about 10 years, and then he was diagnosed. He got to the mid-stage where he didn't remember her anymore. But she knew everything he liked to do, and she would come and she would entertain him with all the things he liked to do, and she had learned to go at his pace. One day he said to her, "I love you. Can we get married?" He hadn't said that in so long. He didn't know who she was anymore. She wasn't his wife anymore. He thought he had a new girlfriend that was getting married, and because she knew him, they were able to get together. And they had a ceremony, and it was beautiful. That was someone who really learned how to work with their loved one, and it was just a pretty story, but it can happen. I've seen it happen so many times with people I've worked with. So we call it recasting the relationship. So as your family member can no longer recognize you, we talk about this whole way of how we look at the disease instead of fighting this disease, because you can't fight it, you can't win. We're going to allow us to change the way we look at things, the way our world is, and we're going to recast the relationship of becoming that person's best friend, of doing the things that when you dated or when you were with them that you enjoyed doing together, and making life meaningful rather than task-driven. Next slide. So in this type of relationship, rather than being a disease of a long goodbye, you're getting to know your loved one better. What delights them? And people say, well, I did that. Well, you can do it again tomorrow, because they're not going to remember. They're going to remember the joy they had doing it. Okay, you can say, Mom, she can't garden anymore. She can't get out there. She can't dig. Something inside of all of us makes us enjoy the hobbies we do. And we know that from the studies with twins, where they're identical and they're remote places that they're doing the same type of thing, whether it be gardening, for an example. Do a modified gardening. Something about nature and that gave that person joy, so you figure out how to do it in a different way. You look at something that's tragic and you say, this is, but how do I embrace the change? This is a disease that has a big D on it. And people used to say that with cancer, but now they have hope. They have things they can do. It's the same thing with dementia. It's a matter of learning about this disease and what we can do and how we recast this relationship to allow our loved one to have a meaningful life and to be engaged. And I've seen people engaged for 10 years, a lot longer than you ever thought. There's a study out in California where people over 90, where 25% of them had dementia, but showed no signs of it because they would continue to be engaged and active. So that I believe we're going to find more and more research, which we already are for exercise and music, that will continue to support higher level of function, and that's really what we want, and better recast relationships with a disease that right now we can't cure, so we have to accept and move forward in a way that's positive for that person's life.
So now let's talk about taking care of ourselves. So signs of caregiver stress. We see lower job satisfaction if you're still working, depression, anxiety, boredom or lack of concentration. You go and spend time with your loved one, and then you come home and you just don't really feel like you can do anything else. Loss of compassion. This goes back to kind of what Beth was saying about having this caregiver burnout, right? You get so angry sometimes and task-oriented, and you're not doing anything that you used to enjoy. You're not doing anything that you used to enjoy with that person. And so we lose that sense of compassion, right? We lose that. Exhaustion, sleeplessness, irritability. And so some ways we can combat that stress, right? Relaxation techniques. I'm sure these are all things that some of you have heard multiple times, right? Breathing exercises, yoga, massage. But one of the things that we really like to stress is just trying to find a sense of community somewhere, right? And I think here there feels like to be a wonderful sense of community. So not being afraid to reach out and ask for help, to ask somebody to come and be with you or be with your loved ones, so you can go do yoga if you've decided to pick up yoga. If you want to just go walk around a store, if you want to just take a walk in your neighborhood, not being afraid to ask for that help.
Okay, so we want to combat no one can do it like I can. Because that is a burden we all put on ourselves, but the reality is we want to do it better. And better means we have to have a community to do that with. So we're gonna talk about ways to get help. Okay, if you're beginning, and you've got your loved one at home, you've got to start thinking about, if I need a break, when is a good time? You don't think about when is a good time for you, but when is a good time for someone else to be introduced into this situation that could help me? So we probably don't want to do it in the morning if someone's not a morning person and they're really, feeling a little bit agitated. Might not want to do it later afternoon if they're having some sundowning and we're trying to manage that. But we try to find that sweet spot of when the day seems to be going the best. Then what we want to do is we want to prepare the person that's going to help us by talking about things that we found that could meaningfully engage their loved one. Talk about how they can receive information, maybe not 3 or 4 sentences, because nobody's going to be trained to do that, okay? Just give them some simple cues, like George loves puzzles. If you come over and do puzzles, you and he could sit and do the puzzles, just give him the pieces, simple commands, and just do the puzzle with him. Introduce people doing things that are easy for them to do, because if you bring them in for the hard thing, because I need to go to an event, and there's a behavioral expression and they don't know how to manage it, they're probably not going to come back to help you again, okay? So I would say pick that time. It might be just going for a walk or going outside the yard, or maybe your friend is a plant person and they bring over a plant, they walk outside and they talk about putting it in a pot, and that whole activity was an hour talking about the pot and coming in and having something to eat. But set it up so it's a meaningful engagement visit when they're first learning to help you, so that they get to that pace of what we're talking about, of how you need to approach your loved one. They can also learn that as well. So with that, I'm going to stop, and Jessica and I are going to take some questions, because we said we were going to give you a few moments, so I'll let y'all do that.
And if you have on your sheet at the bottom, I had put the chair off, and you do it in the first aid, sorry about that. If you have questions that you don't want to ask out, you'll give me a sheet, I'm sure that they will answer what it is we can get to. You have Lauren, it's going to be over on that side, and Martha, it's going to be over on that side, and I'll be on this side, just a hand is in. Or you can raise your hand and ask questions, either way, but you want to carry off.
In the days and nights?
Yes. Okay, what happens, why the days and nights get confused is that we all have a circadian rhythm, and that rhythm allows us to be able to do day and night. What happens is, even as we age, our eyes need 3 times more light. But the other part that also is the amount of light, the intensity of the light that gets to the back of our eye is much greater as we age than when we're younger. So we tell people, if you're starting to have someone where days and nights are getting confused, look at the light in your home. Make it extremely bright, white blue like the sun during the day, and bring it down toward later afternoon when people sundown. Additionally, have that warm glow night in the room, so that's kind of signaling like a campfire signal. The reason they're getting days and nights mixed up is because that circadian rhythm needs to be reset. And so the things that they found that's most significant that reset that and bring down agitation and aggression is light therapy. So if you can get that light in your house, and you can go and look on light bulbs, and I can send you some articles, but if you can get your light bulb, that white blue, about 500,000 lux, and have that throughout the day, and then bring that light down, you get them on one of these apps where you can take the light down lower, you will start to help giving them as much sensory input as you can. The other thing I tell people is you won't change day and night behavior all at once. You change it 1 hour a day. And slowly, you may be getting to the point where maybe they're still getting up at 2. You get them up, you give them something relaxing to do. You have the nice warm light on, not the bright light, which we tend to forget about. Let them get comfortable, go back to sleep, and begin to start changing 1 hour at a time. Additionally, getting outside. Getting outside in the outside light for at least 45 minutes, up to 2 hours a day is significant. Or sitting by a window that's all glass where bright light is coming in, that can also help as well. But we found, I know at a community where I changed the light, I was able to get people to sleep better as well as be less aggressive and agitated. So it does have a powerful impact. Is there another question?
Can you talk about hearing loss, and especially if they're unable
Yeah, hearing loss is incredibly impactful because my vision is already being impacted by dementia, and if I can't hear, it makes it much, much harder to understand. I've got to really look at that person and figure out what they're saying. Hearing aids are going to get lost, and it's going to have to be your job to keep putting them in because they're not understanding what they're there for, really, past the fact that they hear and then it's something that they're fidgeting with. So we even find that people can accelerate the level of dementia by not having the hearing aids in because it's one more impact that they have in a diminished world. So I highly recommend that they wear them, but you're going to have to manage them. They will not be able to manage the hearing aids. Sometimes I've actually found when they keep taking them in and out, sometimes if I put a lavalier on with a voice amplifier, sometimes that's actually working on people. It's not as invasive of them figuring out how to keep going in their ear.
We have a question. Do you have any suggestions for helping in communities that are so task-driven and that have many care partners?
Okay, one of the things I tell people is if you're going into a community and you want to help, find out a little bit about the residents that you're going to be volunteering and helping with. Maybe you have people there that were gardeners, or maybe they cooked, or maybe they were involved in boat building or cars, taking magazines. Picture books are also another way to get people engaged in what we call tabletop activities. So I always recommend when I get families involved, I find out what do people like here? You know their life stories? Do you have some book readers? Is somebody I could read to? Do you have somebody that I could bring this picture book in because she enjoys looking at pictures of dogs? You know, I brought in books of Lassie, I brought in Frank Sinatra. Is there something you could do with just music or bring a group in to entertain with music? But it's finding out, that's why when you sign up, we'll give you this life story of, if they begin to know the life stories of people that live with them, the best way to engage people is meaningful relationship. Far better than doing the task of taking them to the bathroom or whatever, which we think we should be doing. If we just go there for a visit, 1 hour, then go do something that's meaningful. And do it with a magazine, do it with a book. You can do it with watching a YouTube. I did one with the laughing babies with a lady who used to be a midwife. She loved that. We had one man who called pigs. He was a national pig calling champion. We got a YouTube on that. Those are the things you can do, things that build meaningful relationship. So hopefully that's helpful.
Are there any other questions? What is the difference between vascular and frontal?
Okay, there's many kinds of dementia. Now there's a lot of research. There used to be like 1 or 2. There's probably like 50 flavors now. It's all, because they're understanding the brain. Vascular dementia is just simply like it does for your heart, where your veins get clogged up and you're not getting the blood, and when you don't get that blood supply, the neurons die, and then that impacts part of the brain, which brings on dementia. Frontotemporal is a very specific part of the brain that gets impacted. Those people that are journeying with that oftentimes will have memory. They'll still have memory, but they're going to have trouble either with speech and definitely with behavior. They're not going to be able to control their behavior. They're going to be very compulsive. They may do things that, they would have never done before, and they'll get very, very agitated, okay? So we really have to work on a routine with them that helps them manage the day, but they won't lose memory till the latter stages, which is very, very different than Alzheimer's and vascular dementia, where memory is the first sign that we see. With frontotemporal, we either see behavior or speech. They're usually the first 2 things that we see.
Does it progress slower if it is frontal?
Not necessarily. Frontotemporal, we're seeing it with older people, but we're seeing a lot more younger people in their 50s that have it. It's usually a little bit faster than Alzheimer's or vascular, but then I've had one woman now with almost 8 or 9 years of it. So it's very varied. I think they're researching the brain now to say there's so many little factors. I've seen somebody with frontotemporal for it only be 3 years. So it is different for different people, and as they begin to understand the brain more, they're seeing that.
There was very little discussion on nutrition. Could you talk about this thing, do's and don'ts, good and bad as far as nutrition?
Well, I think,
Is coffee and stimulants, is that good or bad?
You know, with nutrition, they are doing some research, you know, and I could send you some information on that because I don't have a lot of time. That's a whole talk. But in general, anything, if you're looking at the biggest types of dementia are Alzheimer's or vascular, that's the largest group. We know that vascular is going to do better with a Mediterranean type of diet, you know, something that's like that. Stimulants, if the person has always had coffee and their body's got that on, that's fine. You just don't want to let them overly stimulate with that. But there is a lot of research. The over 90 study found that people that ate more of a Mediterranean diet tended to do better. This was a study of 14,000 people over a longitudinal 20 years. So that's generally the information that's out there, but there is an awful lot of study about nutrients now related to dementia. So if you want some more information, I can give you a bunch of links on that. I think it's a whole area along with the whole thing that we know with exercise that really needs to be explored a lot more, because research is showing that exercise and music have an impact, and they're beginning to see also the diet may have an impact as well. So that's a good question.
What is the difference between Alzheimer's and dementia?
Alzheimer's is just a form of dementia. There are multiple things under the umbrella. Alzheimer's happens to represent 60 to 70% of all dementias, and 40% of Alzheimer's is a mixture of Alzheimer's and vascular dementia. Frontotemporal is about 10%. You can have like cortical basal, that's like a 1%. There's a variety of different, I guess you call them flavors or different types, but they're doing a lot more research where they're finding out more and more parts of the brain are affected than they originally thought. Lewy bodies is a type. You know, you can get a dementia from Parkinson's, but not all people with Parkinson's will get dementia. Some will, some will not.
What's the latest on early diagnosis for Alzheimer's?
Latest on what?
Early diagnosis of Alzheimer's. I mean, a lot of people, you know, it's maybe mid-stage before they even get diagnosed.
Exactly. I believe that it's really important to get diagnosed early because you can make a plan. I find that if I can work with someone in terms of making their day and the routine easier, getting their diet back to what you talked about, getting them involved in exercise. Exercise is, particularly walking, is highly effective with keeping someone moving. I can generally delay some of the functional changes. I can't change what's going on in the brain, but our body can begin to functionally still be at a higher level if we don't do something. And so I've actually seen people that have come to live with me in a community, in some of the communities, where actually they start functioning better than they did at home. And that's why early diagnosis is important, is to improve the function. It's kind of like you think about when you have arthritis. You can either decide you're going to do nothing and it gets bad and you got to have your limb replaced, or you do exercise and you function a whole lot better and feel a lot better and you give you less damage to your joint because your muscles are taking some of that load. So that's what we're finding with dementia.
I hate to stop the question, but it is 5 after.
Oh, I'm so sorry.
But thank you so much. This has been so before you leave, if you want to have the VD tour, or you can fill out the bottom about other things about Alzheimer's or dementia that you want, if you will hand it either to Lauren and Pete, Martha and Aaron, to me, we will be sure that that happens. And I will call the people that want to be on the 26th tonight.